Usually, when we talk about a medical diagnosis, you expect precision, right? Like you break your arm, the x-ray shows a jagged white line, and the doctor just points and says, there it is.
Right, it's very black and white.
Exactly. But step into the world of the human mind, and suddenly that x-ray machine is broken. You're looking at murky waters.
Oh, absolutely.
So today we're diving into the controversial, constantly shifting blueprint therapists use to diagnose you, and, well, why the label you get today might not have even existed, like, 10 years ago.
To help navigate this, I'll be playing the inquisitive student today,
Yeah.
which I guess naturally makes you the lecturer.
Challenge accepted. So for today's curriculum, we're pulling from section 15.2 of chapter 15 from Psychology 2E.
Perfect.
The main tool mental health professionals use in the U.S. is the DSM-5. That's the Diagnostic and Statistical Manual of Mental Disorders. It basically exists to give professionals a common language, to identify symptoms and guide treatment.
But as the student here, I have to ask, do these categories actually work like clean, separate boxes? I mean, looking at human behavior, it rarely fits into just one neat symptom profile.
No. The boundaries are incredibly blurry. That brings us to comorbidity, which is when a patient meets the criteria for 2 or more disorders simultaneously.
Oh, wow. So they overlap.
Heavily. Section 15.2 actually notes that 41% of people with obsessive-compulsive disorder also meet the criteria for major depressive disorder.
41%. That's huge.
Right. And if you look at substance use disorders, 6 in 10 of those patients have another mental illness.
Which has to make treatment just incredibly tricky. I mean, if the symptoms overlap that heavily, how does a doctor know if the depression is causing the substance abuse or the other way around?
It's tough. A classic way to think about it is, well, like a house with a leaky pipe causing electrical damage.
Okay, I'm following.
You can't accurately assess or fix the wiring, which is the underlying mental illness, until you turn off the water.
Meaning doctors often have to wait until a patient stops using drugs or finishes withdrawal just to see the actual baseline of their mind.
Precisely. You have to shut off the water first.
Though, I mean, that almost makes it sound like one condition always causes the other. Couldn't the structure of comorbidity be more like, say, a single weed with multiple roots showing up in different parts of your garden?
Oh, I like that.
Like the OCD and the depression might just be 2 visible symptoms sprouting from the exact same underlying neurobiological root.
That is a brilliant way to look at it. And because of that tangled root system, the borders defining these conditions are constantly shifting.
I'd imagine the manual has to change a lot then.
Drastically. The first edition in 1952 had 106 diagnoses. The DSM-5 has 237.
Wait, so they more than doubled? Are we just getting better at identifying distinct illnesses, or are we, starting to over-pathologize the normal human condition?
That is the exact pushback critics raise. Take the bereavement exclusion.
What's the...
Well, in older versions of the DSM, if you were grieving the death of a loved one, doctors wouldn't diagnose you with depression. The grief was considered normal. But the DSM-5 removed that exclusion.
Wait, so if I'm grieving a massive loss, a doctor could technically diagnose me with major depressive disorder?
Yes. The authors argued that severe grief can trigger genuine depressive episodes that require medical intervention.
But that essentially slaps a medical label on the natural human process of mourning.
Exactly, and that's the massive criticism. And it gets more complicated when you look outside the U.S.
Right. What does the rest of the world do? Is the DSM the only diagnostic tool used globally? Like, is an illness in New York classified the same way in Paris?
Effectively, no. While the DSM dominates U.S. research, the textbook points out that the rest of the world heavily relies on the ICD.
Which stands for?
The International Classification of Diseases. It's published by the World Health Organization and used much more frequently worldwide for actual clinical diagnosis.
It's wild to think that we have entirely different diagnostic lenses for the exact same human experiences just based on geography.
Right. And because these boundaries are so fluid, the text highlights a crucial rule of compassion. A psychological disorder represents an extreme of a normal inner experience.
Meaning everyone feels sad or anxious sometimes.
Exactly. But it only crosses into a disorder when it becomes highly disruptive. And practically speaking, a person has a disorder. They are not the disorder.
Right. You wouldn't call someone a cancer, so you don't objectify someone with a mental illness.
Because the label is just a tool for the doctor to use, not a permanent identity for the patient. So for everyone listening, remember that diagnosing the mind isn't a rigid science.
It's a continuous attempt to categorize something incredibly complex.
Which leaves us with this final thought. Nearly half of all Americans will meet the criteria for a DSM disorder in their lifetime.
That's a staggering number.
It really is. So if our definitions of normal keep shifting this rapidly, might future classification systems abandon these rigid diagnostic boxes entirely?
Yeah, maybe instead of looking for that clean X-ray of a broken bone, we'll finally just map the fluid spectrum of the human experience.